Welcome to podcast 3A.
Welcome, I'm Fran.
And I'm Minnie.
So this series of podcasts aims to bring education to you, the clinical officer, in your setting. As we've mentioned, the first 4 podcasts we are recording are a trial. So we need your feedback, both positive and constructive. Yeah, we can take it. And also let us know if there are any future topics you'd like by contacting us via the forum.
That's great, Fran. So this podcast tip, as we mentioned, we are giving you a tip with each podcast, is to use the specialists that we have available for your cases. So when you're choosing your clinician, select from the drop-down option the clinician that you require. And we have a specialist respiratory consultant. So for your more complicated respiratory questions and problems, please select the respiratory consultant.
Fabulous. So we've done respiratory history in the previous podcast. So this is 3A because respiratory examination is quite a complicated thing to talk through. So part A is what we can glean just from observation of the patient. And part B, which will be a separate podcast, is when we're doing the hands-on examination. Fantastic. So, Minnie, what can we learn just from looking at the patient?
So, as you mentioned to me before, Fran, quite a good tip is to go along to the waiting room and call your patient in, and as they're walking towards you, you can watch them and get lots of information. You're playing the detective. We are playing the detective. And so the first thing, the most obvious thing is, their age. Is this a young patient? So what illnesses are going to be more likely in younger patients? Could it be asthma? Could it be cystic fibrosis? Could it be a viral cough, which is incredibly common in young children? Or is it an older patient, in which case you'd be thinking maybe about other illnesses, something like instead of asthma, it might be COPD, which would be smoking related. Could it be a malignancy? Okay. And the other thing you can see along with that is whether they're carrying anything with them. So are they clutching their inhaler or have they got a packet of tissues? That sort of thing that may make you think. Go on. Yeah, fantastic. And I very often when I examine patients, they're in their hands, particularly old women, always seem to be clutching a dirty tissue, which is not my favourite thing to come across during an examination. And then the other thing, so where I work, I'm at the end of a very long corridor, so I have a lot of time to observe my patients. And particularly with respiratory things, is that patient short of breath? Are they struggling to walk down the corridor? Or if you're in a hospital setting, when you come across them, how are they sat? Yes, that's really useful, isn't it, Fran? Yeah, so when people are short of breath, how do they tend to sit, Minnie? Well, certainly there's something called the tripod position, where a patient will sit with their arms outstretched in front of them, leaning forward, bracing their chest to help them breathe in and out. So that's something somebody does when they're feeling very short of breath? Yes. Right. So you would probably see that they are breathing quite quickly as well. Okay. When they're sitting in that position. Yeah, and they might have pursed their lips to try and alter the concentration of CO2. And in smaller children, you'd notice much more obviously things like nasal flaring. Yeah, yeah. And sometimes also their head bobbing, that sort of thing. And also the use of accessory muscles. And particularly, I always tell parents to watch for this, that the recessions that they get, the indrawing in between the ribs, which shows that they're working much harder. Exactly. No, that's very important. So then, although, we're calling it inspection, when the person starts talking to you, you can then get an idea of how short of breath they are. So if they're unable to manage a full sentence, that gives you an indication. Or if they're very chatty and not struggling to breathe, again, that gives you so much information. Yeah. And while they're speaking, you'll obviously be looking at the patient's face, and you'll be able to determine whether or not there's any cyanosis, so any bluish, purplish discoloration either of their lips or of the fingers. You can also look at their hands at the same time. And what does cyanosis mean? So cyanosis is when the saturation of the oxygen in the bloodstream is usually about less than about 85%. That's usually when you'll start to see any clinical signs.
Okay, and that can be useful because I know, although I have a very simple machine that measures oxygen saturation in general practice, that actually probably in Zambia people don't. So being able to look for that to give you an indication of what their oxygen saturation might be is incredibly helpful.
Yeah, very useful.
Yeah.
Yes. Is there anything else that we might be looking for, Fran, as the patients sitting, making themselves comfortable in front of us?
Yeah, so I'd be looking to see if they're cachexic, so that is if they are very thin with muscle wasting. So that comes in lots of conditions. So it doesn't necessarily specify, but it gives you an idea of how unwell that person is. So conditions that would cause cachexia are wasting illnesses, things like HIV, cancers, and even with COPD, patients can become like that.
Okay, so that gives you quite a broad spectrum of things to be thinking about, really, doesn't it?
And then sort of as well as looking, we're also using our ears, aren't we, whilst that patient's coming towards us? And what sort of things might we be hearing?
So we'll be listening out for cough, and as we discussed in our previous podcast about cough, what is the character of that cough? So you'll be able to tell whether it's a productive cough, a dry cough, or whether it's a barking cough, or if there are any other noises present while the patient's breathing.
Yeah, so other noises would be what sort of thing?
Well, wheeze, which we've mentioned before, and also stridor, and these two things really need to be picked apart, and you need to be very sure of the sound that the patient is making. So with stridor, this is an inspiratory sound, so as opposed to wheeze, which is expiratory, so on breathing out. So stridor will give you an indication that the obstruction is upper airway and not actually lower down in the pulmonary area.
So what sort of illness gives you an upper airway obstruction?
Well, illnesses, you're looking at croup, and epiglottitis, which obviously the patient would be presenting in a very sick way. They'll be very unwell. So you'd certainly have lots of other clues that the patient was poorly. But also in young infants, parents often will bring them in with noisy breathing, which is stridor, which is because they have a floppy larynx. And in most cases, this isn't laryngomalacia. That's right. So this isn't usually too much of a problem and something they grow out of, but sometimes does need further investigation.
Yeah.
Tell us about wheeze.
So sorry, Minnie, to interrupt. I just wanted to go back to epiglottitis because that isn't something we see in the UK very often because we have the Hib vaccination, but is possibly something you might see in Zambia more, and that is a medical emergency. And you need to be very careful not to look in the patient's mouth if you suspect that.
Well, that's a very important point.
Yeah, so wheeze we've talked about before in the previous podcast. So we're talking about asthma, COPD, possibly bronchiectasis with that. So I'm hoping you all feel confident now, having listened to the previous podcasts about what a wheeze is and what illnesses that might signify.
So we'll move on from just looking at the patient to looking at the patient a little bit more closely and looking at the hands. What things will we be looking out for in the patient's hands to give us some respiratory pointers?
So, I mean, the most obvious thing that you might notice is tar staining on the fingers. So that tells you that they're a smoker, and immediately from that, you know that they've got this increased risk of having smoking-related diseases such as emphysema, COPD, and lung cancer.
Okay. Yes. Yeah. Okay. And other things that we can look at are looking at the nails, looking for clubbing. So this is where you lose the angle of the nail bed. If you hold your index fingers together, nail to nail, you lose the window that you see between. And I think that's the best way to describe it, really.
Yeah. And what sort of illnesses cause clubbing?
Well, it varies with the age groups, but in children you might be thinking about cyanotic congenital heart disease, liver diseases, inflammatory bowel disease as well can cause it, but also in the older patients you'll be thinking more about lung cancer, bronchiectasis, sort of chronic lung problems.
And just also say that there are some people that have it as a normal variant, something that they've had from birth and then they've had lung conditions. It may little variation for them and isn't clinically significant. But yeah. And then going back, so we already talked about the cyanosis, looking at the patient in the face, but also you can get that in their nails as well. So you'd look there again for that.
Okay. And other things that we look for in the hands are joint swelling, nodules, things that might present with extrapulmonary features, such as rheumatological diseases.
Okay, so something like rheumatoid arthritis, for example, where you can have very, very deformed hands, can't you, with particularly swelling of the small joints. And I know that can cause problems with pulmonary fibrosis and nodules. So you're looking, like Minnie said earlier on, you're a detective and you're looking for signs to what might be causing these respiratory symptoms, and all these things are little clues that you can then piece together to form to complete your puzzle.
Yeah, excellent.
And so what else would we be looking at? The final thing on the hands that you'd be looking at, what would that be?
Just looking at skin changes, because if patients have been on certain medication, like long-term steroid use or things, you get thinning of the skin and easy bruising. And so this will make you think about things like asthma and COPD.
Yes. And also, sorry to leap around a bit, but with long-term steroid use, when you're looking at them, you may well see some sort of what's called Cushingoid features. So they get very chubby in the face and they get central adiposity. So that's a smart way of saying that they get fat around their tummies. So long-term steroid use, which people are sometimes on for respiratory diseases such as asthma or interstitial lung disease, that has side effects, as do most medicines, and you can see those quite often when you look at a patient. Okay,
let's move on a little bit to the wrist, and we'll feel for the pulse and look at the feel for the rate and rhythm, because obviously there are certain conditions which will give you an increased pulse rate, like if you have an infection with fever, or if you're using a lot of salbutamol, both those things will give you a tachycardia.
Fantastic, And then cardiologically, if you have a very slow pulse rate, because there's something wrong with your heart, that can also sometimes make you feel short of breath because your heart isn't getting the blood round through your lungs. So checking the rate and making sure it's with making sure what it is and recording it is incredibly helpful. And not just the rate, as Minnie said, the rhythm. Is it a regular pulse or is it irregular?
That's important, isn't it, actually?
Yeah. And then if it is irregular, does it have a pattern to it? So is it, 3 beats and then 1 dropped, 3 beats and 1 dropped, or is it completely all over the place? So if it's completely what we call irregular, that tends to be a cardiac problem called atrial fibrillation. And again, we'll talk about cardiac problems in future podcasts, but that if someone's going very quickly in that rhythm, that can also make people short of breath. So all these things, they can all contribute.
So we need to bear all those things in mind.
Yeah.
And obviously, importantly, we need to also assess the respiratory rate of the patient, especially as we're dealing with a respiratory examination.
Yes. And so just to say that a normal adult range is between 12 and 20 breaths per minute. And we're going to do a future podcast, aren't we, Minnie, on children, where we'll explain their rates, because it varies according to age. Okay. So what would you be doing next?
So we'll move on from just the general inspection in the hands to the head and neck of the patient. Obviously, we've already discussed looking for central cyanosis, but we can also look to see if the patient is pale. So we'll look at the conjunctiva. It's a good place to have a look, just gently pulling down the lower lid to inspect this. And if you have it's quite a significant anemia, you will see pallor in this area. So I think it's often recorded about a hemoglobin of about 7 grams per deciliter, you'll actually see clinically. So really quite anemic.
And anemia was associated with being short of breath?
It is indeed, Yes.
Right.
So that is another way that shortness of breath can present.
Fantastic. And then, and so what else would you look for in head and neck?
We've already mentioned the central cyanosis, so that you actually need to look at the colour of the lips and the underside of the tongue to look for blueness there. And then there are other signs like Horner's syndrome, which is another thing to look out for, where you get drooping of the eyelid, that's a ptosis, constricted pupil on the same side, and loss of sweating on that side.
Okay, and Horner's syndrome is associated with what illness?
Well, it's particularly associated with malignancy. Is that correct?
Yes, it is. So it's an apical. So that's up in the top part of your lungs, in the cancer in the top part of your lungs, which then constricts on the nerve, and that's why you tend to get a Horner's syndrome. So I mean, it's something
not that
we're all.
Common.
It's not that common, but we're all taught about it. If you see one, let us know on the forum, because that would be fantastically interesting for us. Yeah.
Okay.
Right. So moving on. So we're then going to look at the chest, so at the thorax, and see if there's any clues there for our ongoing detective work. So
we obviously need to expose the chest at this point, Fran.
Yep. Yes, we do. Because if you don't, then you can't see exactly what's going on. So I'd be looking for scars, and these may vary between the UK and Zambia, but in the UK, I'd be particularly looking for scars that indicate any sort of surgery or give us any clues to previous things. So scars from chest drains, scars from previous surgeries on the lungs, or scars from other conditions. So if somebody's had breast cancer and they've had a mastectomy, you might be thinking, could their shortness of breath be their cancer that's spread to the lungs? So all of these would be clues.
Fantastic. And also, when you're mentioning previous medical problems, if you look at the skin as well, you may see some changes that give you clues about that. If they've had recent or previous radiotherapy, the skin may look reddened or thickened.
Yes.
So all these things are just giving you more clues, really, as to what might be underlying.
Fantastic. And then, again, sort of going back to major surgery, there may be some asymmetry in their chest because they've had some treatment. And there may also be asymmetry from deformities.
Yes.
So you can get an illness called, a deformity called pectus excavatum, which is also called funnel chest. And that's
what's this, Fran?
So this is when the sternum is sunken deep in, and this can be associated with connective tissue disorders, and if it's severe, this can cause breathing problems.
Okay.
Pardon me. And then contrary, you get something called pes carinatum.
Is that the pigeon chest?
That's the pigeon chest, yeah. And that's the opposite. So instead of being sunken, the sternum is sticking outwards, and that's associated with asthma, with scoliosis, which is a curvature in the spine, and with a mitral valve prolapse.
Okay, so those are again a good pointers to underlying conditions. And in someone with COPD, for example, you'd get quite a barrel chest, wouldn't you?
Yeah, you can do. So that kind of concludes the things that we'd just be looking at. So that's quite a lot of information. And although, we've talked through it and it's taken time, actually that's very quick when you're examining a patient. You're picking up on all these clues very, very quickly. It should only take you 2 minutes to gather all that information.
Which is fantastic, isn't it? Fantastic amount of info.
Yeah, definitely. And then please go on and listen to our next podcast, which will be part B, which will complete the respiratory examination. And as we said, that's going to be dealing with the hands-on things, so the auscultation and the percussion.
Fantastic. So meanwhile, if you've got any questions or any feedback, please get in touch with us via the forum.
Brilliant. Well, that's goodbye from me.
And from me. Bye.
Bye.